Welcome to the Geriatric Patient with Dementia in Long-Term Care, Assessing and Managing Behavior Disturbances. I'm Dr. Martin Forsberg, Assistant Professor of Psychiatry with the University of Medicine and Dentistry of New Jersey School of Osteopathic Medicine. This presentation is supported by an educational grant from the Donald W. Reynolds Foundation Aging and Quality of Life program. The learning objectives are to assess behavior disturbances, underlying causes, and implications on care, to be able to efficiently gather data from multiple sources, to review common instruments for screening for dementia, to formulate a management plan considering risk-benefit analysis and regulatory issues. First, let's talk about the facility. This case takes place in a long-term care facility, or LTC. This is synonymous with a nursing home. And sometimes this is a part of a CCRC, which stands for Continuing Care Retirement Community. And this means that a resident may move in as an independent living resident in an apartment requiring very little assistance, may advance to assisted living where they require some degree of supervision and perhaps help with medications, and if they need, they may advance to long-term care where they would require more skilled nursing care. These facilities are inspected annually based on federal regulations established by CMS, which stands for the Centers for Medicare and Medicaid Services, and the inspections are done by state inspectors. So when we look at where the funding comes from, first, people are expected to pay privately. The second form of payment would be from long-term care insurance if a person had planned ahead, and once a person's personal funds and assets are exhausted and they qualify for Medicaid, Medicaid will pay for long-term care. Medicare will not. The criteria for admission are that a person must be dependent on 3 activities of daily living, or 2 if they have dementia, and they must require 24-hour nursing care. This is the case of Mrs. T. We will be approaching this case from the perspective of a geriatric psychiatrist who's providing consultation. We have a patient, Nora T. She's in room 125D. It's not uncommon for these facilities to be quite large and have over 100 residents. It is also not uncommon for people to be sharing a room with up to 3 other people. However, most of the time rooms are divided with a curtain with 2 residents. According to the staff, the urgency on this consult is immediate. They want the person seen as soon as possible with an exclamation point. The reason given for the consult is simply that the patient is combative, and the ordering physician in this case is Dr. Applebaum, and this is important because when obtaining a consultation, there must be medical necessity for Medicare to consider paying for the service. Medical necessity is demonstrated only when a physician or a nurse practitioner indicates so in the medical notes and with an order. It can also be established by the consultant for follow-up appointments once they've already seen the person, but nursing and family cannot order a consultation. Medicare will object to that payment. These are the elements that we use in approaching the geriatric consult in long-term care setting. Of course, we want to obtain history, medication review and reconciliation, a psychiatric evaluation. We must establish a diagnosis and an initial plan, and a follow-up plan. The components of the history are a chart review, where we're reviewing the current episode, but also any history of previous episodes. We can learn a lot from looking at past episodes and what the course of that episode was and what treatment interventions were effective. We also have the luxury of collateral information from nursing, certified nursing assistants, and activity and restorative therapy staff. Families are often involved and can be used as collateral, but these are collaterals which are generally around all the time. We will conduct a medication review and reconciliation. So the history that we have is that Mrs. T was placed in this nursing home 9 months ago after her husband died. He was her caregiver. This is a very common situation. At home, she had been mistaking him for a stranger and attacking him with her walker. At home, she was on Seroquel 150 milligrams TID, and Seroquel was lowered to 100 milligrams BID 2 months ago. And she'd been on Cymbalta and Aricept for 2 years. You can see her past medical history listed below. You notice that she has hearing loss and won't wear her hearing aids, and her past psychiatric history is significant for recurrent mild depression, and we don't have any further details. This is usually the situation we're in, where we have a partial history. We know that this is an 85-year-old woman. She's widowed with no children. She's a retired waitress and used to work at a 24-hour diner. She was admitted after a fall, a hip fracture, and a hip replacement. She has a niece who visits monthly. She's on Medicare as well as Medicaid, which means that due to her work history and age, she qualifies for Medicare and Social Security. Due to the fact that she's exhausted her personal resources, she is on Medicaid, which is paying for her stay in long-term care. She has no history of substance abuse. Next, we're looking at her medications in the medication review and reconciliation. We're looking at the prescription medications on the left, and we're noting the total number of medications, we're noting the dosing schedule, and whether the doses seem reasonable. We also look at the non-prescription medications that she takes, and they're listed on the right. Now, let's take a minute and think about several things pertaining to this case. Let's go through them one by one. Why was this patient on Seroquel? She was likely started on Seroquel, an atypical antipsychotic, for dementia-related behaviors rather than for a primary psychotic illness such as schizophrenia. Now, it's important to note that there are no FDA-approved treatments for dementia with behavioral disturbance, and in fact, the FDA, or Food and Drug Administration, has issued a black box warning in using atypical antipsychotics in people with dementia. This is due to the increased rate of mortality, and this will be discussed shortly. When using atypical antipsychotics for dementia, it is important not to dose them the same as you would for primary psychotic illnesses. But for the lack of a better treatment, many patients are placed on antipsychotics for these behaviors. Doses as high as the 200 milligrams a day that Mrs. T is on may be causing excess sedation, and we may see that play out in this case. Next, what's the evidence for antipsychotic use for dementia-related behaviors? There are a few blinded studies that actually show clinical benefit. However, the benefit tends to be modest. Risperdal seems to be the best studied and the medication with the most evidence for effectiveness. Now, these dosing ranges are between 0.25 milligrams and 1 milligram. These are doses much too small to be used in people with, say, schizophrenia. However, they tend to be all that's needed to achieve the best possible outcome. Doses higher than a milligram tend to cause more side effects than benefit. There is a large landmark study called the CATIE study, and the AD portion of this study studied antipsychotic use in dementia with related behaviors. The primary outcome of this study showed that these medications were comparable to placebo. The medications that came out with the best evidence for effectiveness were Risperdal and Zyprexa. Zyprexa tended to have more side effects than Risperdal, and what can be gained from a study like this is that these medicines do not have great evidence for efficacy, and that placebo has efficacy even in a population with dementia where you would not expect a placebo response. You're seeing a placebo response, and this may reflect either caregiver factors or that allowing time to pass and paying individual attention to residents may also have a clinical benefit. As mentioned before, the black box warning is in reference to the increased risk of mortality. The hazard ratio is 1.6, or 1.6 times the rate of mortality which would be considered pre-existing for this population. An interesting study showed that these medications do not improve quality of life for patients or caregivers, which is often surprising to learn and often very surprising for caregivers at home or in care facilities. Therefore, we must always use informed consent with the patient's family, or responsible party, and involve them in a risk-benefit analysis to determine if this type of medication is warranted. Should Cymbalta be continued in this patient? The American Psychiatric Association has issued guidelines for the treatment of recurrent major depressive disorder. Continuous use of antidepressant treatment is warranted if there's risk for relapse. When a major depressive disorder is considered recurrent, there is possibility for relapse, and therefore continued use would be justified. When responding to requests for mandated gradual dose reductions of psychotropic medications, reference to the condition being treated and the guidelines that justify treatment should be documented. We'll talk about this more. What are the benefits and risks of acetylcholinesterase inhibitors? We do know that there's evidence of benefit in mild to severe Alzheimer's disease. However, the clinical effect size is small, meaning that the magnitude of improvement sometimes does not reach what we would consider clinically relevant, even though it may be statistically significant. And we think that all agents are equally effective. Even though there's no FDA indication, it does appear that dementia with Lewy bodies and vascular dementia can be improved with the use of acetylcholinesterase inhibitors. The common side effects are GI upset and vivid dreams, and there can be an increased risk of GI bleeding and loss of appetite. Now, the serious risks are displayed below, and they include syncope, bradycardia, pacemaker placement, and hip fractures at the hazard ratios shown. Now, a hazard ratio of 1.75 is nearly double in risk. This should be appreciated and considered when using even medications thought to be as benign as acetylcholinesterase inhibitors. Now, looking at the collateral information that we have, the nursing tells you she rolls up to other patients, yells at them, hits them. She fights with us when we bathe her, stays up all night, she's mean to the CNAs. She was put back on Seroquel a month after the consult pharmacist told us we had to stop it. something about a mandatory dose reduction. The CNA, or certified nursing assistant, tells you she's terrible this week. She fights during care and talks to her dead husband. She needs to be on something. Now, this is not an uncommon set of reports. We can first say that it's important that these observations are documented. When we're using medications with such a propensity for risk and such scant evidence for effect, there needs to be justification documented in the chart. And these behaviors will justify the use of these medications in most cases. It's also interesting to look at the language used to describe the behaviors. Look at the word mean and look at terrible. It really does place a judgment on the patient that's exhibiting these behaviors. These behaviors, in this case, are due to dementia. When the person has little or no control over these behaviors, we must be cautious when assigning judgments. It's also interesting that you often are asked to put the patient on something, when in fact there may not be anything that's safe and effective for the patient. The act of leaving a patient without medications can sometimes be seen as not appreciating the difficult nature of the behaviors. These behaviors can certainly be very difficult, and especially the certified nursing assistants can tell you this because they're dealing with the personal care of a resident day in and day out. We can also talk to the activities staff, and here we learn that Nora used to be very quiet and sleepy a few months back. She started doing more in activities, but was becoming more and more confused and disoriented. She sometimes asks to kick these bums out of here. They're not ordering any food. Here we may be seeing the effect of the dose reduction of Seroquel that occurred 2 months ago. Before the reduction, she was very quiet and sleepy, which some people might feel is a more favorable outcome. However, once the Seroquel was reduced and the sedation was reduced, people started noticing that she was doing more, but they were also noticing that she was quite confused and disoriented. When she is talking about kicking the bums out, she could be reliving her occupation, which was, as you remember, a waitress in a 24-hour diner. It's not unusual for people who are not able to orient themselves or rely on their short-term memory to revert back to their occupation or older memories, and may sometimes act accordingly. Now, when we meet Mrs. T, we find that she's alert, pleasant, makes good eye contact. She's not oriented to place or date, and she's very interested in us meeting her husband, who she believes is out in the hallway, and she's calling for him. When asked, she has no complaints. When we do our physical exam, we find no cogwheel rigidity or tardive dyskinesia, which should be the part of any exam on somebody before or during treatment with an antipsychotic. For our mental status exam, I often look at these headings that you see on the left, which include appearance, speech, affect and mood, thoughts, and sensorium and cognition. We see that this is an 85-year-old woman. She's self-propelling herself in a wheelchair. She makes good eye contact and is able to sustain a superficial rapport. She's hard of hearing and, like we noted earlier, doesn't want to wear her hearing aid. Her speech is of normal volume, rate, it's coherent, and she repeats certain ideas. She says her mood is fine. Her affect is actually euthymic. Her thoughts are not exhibiting any suicidal or homicidal ideations. She has no auditory or visual hallucinations. Her associations are actually fair. We would describe her thinking as delusional when she feels that she still works and her husband is still living. She's only oriented to self, and she has poor short and long-term memory, and we would say her insight and judgment are both impaired. Now here's some other things to think about. Let's take a moment to think about these before we move on. How do you distinguish between dementia with behavioral disturbance and delirium? So this can be difficult. Delirium is distinguished by acute onset, a fluctuating course, say over the course of a day or a few days. There's impaired attention, and there's often sleep disturbance, if not a complete reversal of the sleep-wake cycle. In dementia, you're going to have an insidious, gradual onset, and you would be expecting a gradual decline without the impaired attention or altered level of alertness that you could see in delirium. It's important to recognize that dementia and delirium can coexist, but when delirium is present, it must be addressed primarily. How do you confirm the diagnosis of dementia? If a person has been formally diagnosed with dementia, repeat dementia workup is not necessary, but you may want to routinely monitor measurements such as the mini-mental status exam or other instrument to document the gradual decline. If you find atypical symptoms such as visual hallucinations in somebody who was thought to have dementia of the Alzheimer's type, may prompt a reassessment of the diagnosis or just a refinement in the type of dementia that you think you're treating. The only gold standard for the diagnosis of dementia is usually at autopsy, so we do not have the luxury of any diagnostic confirmations at this point in time. Are there reversible causes of dementia? There's only a few that are truly reversible. Under these headings, you see different conditions. Under metabolic, you have vitamin B12 deficiency or cerebral anoxia. Under infectious, you have syphilis or encephalitis. If you have a traumatic event such as a hemorrhage, you may expect the cognitive impairments to improve with time if the hemorrhage is evacuated or absorbed. You can have toxic causes of cognitive impairment such as medications or illicit drugs, and certain structural features that can sometimes be surgically addressed can be causes of reversible dementia. Screening test for dementia. Let's take a moment to look at the sensitivity and specificity and certain aspects of these tools. The mini-mental status exam, which is also referred to as the Folstein MMSE, has a sensitivity of 79% and a specificity of 88%, which is pretty good. It's commonly used, but it's copyrighted. It does give you a score between 0 and 30, which can be followed over time. Another short test called the mini-cog has a sensitivity of 76% and a specificity of 89%, which is pretty close to the mini-mental status exam. It's very quick, but it doesn't have a result which can be readily followed over time. It's more of a binary result, meaning it's either positive or negative. The mini-cog has a component of it which includes a clock draw, but a very formalized clock draw test is called the clocks, and there's clocks 1 and 2. You can see the sensitivity and specificity noted. The clocks 1 assesses executive function, which is highly correlated with ability to sustain yourself in independent living or assisted living, or whether you might need 24-hour nursing care. You also see that the clocks 2 can be used to assess visual spatial function, which can have certain predictors in mortality. When we use these tools in the case of Mrs. T, we see that her mini mental status exam score is 16 out of 30. The mini-cog was scored as a positive screen for dementia because she only had 1 out of 3 recall, and she was not able to draw a good clock. The clocks 1 and 2, which I will show images of, show poor executive and visuospatial function. Sometimes you may find that a person scores well on an instrument such as the mini mental status exam, but your gut feeling is that the person has certain difficulties. So using a tool such as the clocks, especially clocks 1, can demonstrate that what you're noticing is poor executive function, which can correlate very highly with the person's ability to live independently. The clocks 1 basically gives the instruction for a person to draw a clock with the hands and the numbers on the face so that a child could read it, and the time should be showing 1:45. Those were the instructions given to this patient. She produced the design that you see. This can be scored using the scoring legend. She scores a 2 out of 15. The clocks 2 asks the resident to observe as you draw a clock and then to copy it identically on a space to the right. As you can see, even though there are some numbers that are legible, there are major problems with visuospatial orientation. When we look at the patient's physical exam, we are looking at vitals, which have been stable. Physical exam, which is often done by the primary care physician, has been unremarkable for many months. The patient shows routine voiding and bowel movements on the log that's kept by the CNAs. And this is important because bowel function and voiding can both represent hydration and nutrition, as well as indicate that there may be a problem with elimination that can have psychiatric or behavioral manifestations. Labs were largely normal. There's trace white count in the urinalysis and a very small amount of colonies in the urine culture. We do have a CT of the brain from 4 years ago which showed cortical atrophy and periventricular white matter changes, which, as you know, are quite nonspecific and are often seen in people without dementia, so cannot be used in diagnosing dementia. How do you approach the treatment of behavioral problems in a patient like this? What we want to do is assess the frequency and the intensity of these behaviors. We need to basically determine whether this is a problem or not. We need to determine the distress to the patient and the distress caused to others. Oftentimes we might be in a situation where the behaviors do not cause distress to the patient but are very disturbing to others. We need to consider the dangerousness of the behaviors. And we're also looking to see if these behaviors are the expression of an unmet need. We're looking at the history of similar behaviors and what has been effective in the past. And we also want to start with the least restrictive intervention first, before we move on to things such as medications, which, as we've spoken about, carry the risk of mortality. When we're talking about dementia with behavioral disturbance, we need to understand that it's very common for people with dementia to develop a behavioral disturbance at some point in their illness. And this is often what leads to long-term care placement, along with incontinence. Once somebody becomes physically aggressive, it is often not long before the family is determining they're unable to care for the person at home. There's no FDA-approved pharmacologic treatments, and most appear in the moderate stage of the dementia. These conditions can improve with behavioral interventions, and when we're referring to behavioral interventions, we mean an activity or exercise program, environmental modifications, reminiscence therapy or distraction, and caregiver education. There's a large evidence base that behavioral interventions are effective, and it often involves modifying the environment and the stimuli that the patient is exposed to. You get the best results when you use a team approach and everybody's on the same page and giving consistent treatments and feedback. Activity programs must be targeted at the resident's level of functioning and interests, and this I think is obvious, but oftentimes you will see a group of residents expected to participate in the same activity when there's clearly only a few residents who are cognitively able and the rest are not engaged. There are activities for all levels of dementia. When you're giving recommendations that involve altering the environment or the actions of the staff, you may face resistance because additional staff may mean additional costs to the facility, whereas the use of medications often does not cost a facility anymore. Now we're at the assessment. For Axis 1, we've given the diagnosis of senile dementia of the Alzheimer's type with behavioral disturbance, along with major depressive disorder, recurrent, and full remission. Axis 2 is deferred. Axis 3 includes the patient's medical problems. Axis 4 includes social, financial, and chronic medical illnesses. Axis 5 was determined to be 40. Next, for our plan, we're going to be recommending a non-pharmacologic approach, but we're not going to stop the medications yet. We understand that these medications sometimes play an important role in the staff's confidence level in managing these behaviors. What's most important is that the staff are confident and willing to work along with you in these approaches. There are also no immediate side effects to these medications, but ultimately we know that this patient would be better off with less Seroquel if it can be tolerated. Cymbalta will be continued as per the guidelines to prevent relapse of a major depressive disorder. And since Aricept is not causing any side effects that we can tell, it will be continued for the possible benefit that it's providing. And in the future, we can consider Namenda as an addition. We happen to be in a nursing home where the staff are very proactive and agree to try a non-pharmacologic approach. We give an in-service to the team about the care plan. The patient is given an activity which is occupation specific, and in this case we're going to have her take food orders from the staff and prepare the place settings. This is well within her current cognitive abilities. The family prepared a photo album which is used by the staff when the patient needs redirection or distraction. We call this reminiscence therapy, and it gives the person that's attending the person on a one-to-one something to do to engage the patient. We know that the patient isn't wearing her hearing aids, and this could be because they're not comfortable. The hearing aids can be very expensive, but sometimes inexpensive hearing amplifiers can be obtained and used intermittently, and they are generally pretty comfortable. Let's take some time to think about how federal regulations impact your treatment plan. Now, it would be nice if we didn't have to consider these. However, we are working in a very highly regulated environment. Most of these modern requirements come from OBRA 1987, also known as the Nursing Home Reform Act. And this is a regulation to improve safety and quality in long-term care. And this has actually succeeded to a large extent in reducing and eliminating the use of restraints. And it's prompted reevaluation and monitoring of psychotropic med use. So these federal regulations are called F-tags, and I picked out a few that have relevance here. F329 speaks to unnecessary medications. It states that psychotropic medications must be tapered quarterly for anybody in a long-term care facility unless it's clinically contraindicated. And in one case where it's contraindicated are in people with chronic mental illness where guidelines support continued use, and you're exempt if you can properly document this. Another time when a gradual dose reduction will be contraindicated is if the person has failed a previous gradual dose reduction. And when we talk about restraints, it's good to know how the federal government defines restraints, and this is in FTAG 222. Here, physical restraints are defined as basically a device that restricts freedom of movement, which includes having a recliner, which the patient cannot easily stand up from. Chemical restraints are drugs that are used for discipline or convenience and not required to treat medical symptoms. Discipline is an action taken by the facility for the purpose of punishing or penalizing residents, which I think happens rarely, but convenience does happen with some frequency, and it's described as any action taken by a facility to control a resident's behavior or manage a resident's behavior with a lesser amount of effort by the facility and not in the resident's best interest. There are some models of progressive long-term care. These emphasize privacy, such as using a single room rather than a multi-occupancy room, having a smaller home-like environment, and contact with children, animals, and plant life. There's often a communal cooking area and dining area. It's important since people with dementia tend to still respond to meals and routines that are deeply ingrained, such as meal times. Also, plants, animals, and children tend to evoke pleasant emotions even in people with fairly severe dementia. Some examples include the Eden alternative, which implements some of the previously mentioned ideas, and the Greenhouse Project, which is the construction of a long-term care facility with a deliberate focus on resident-centered care and employing the principles of the Eden alternative. In our follow-up in our case, the patient still yells out for her husband. She can be redirected and distracted when she gets upset about other residents. She stays up late, but is allowed to sleep in. Remember, this is somebody who could have been working the night shift for most of her life. We should be sensitive to what her needs are for sleep. Seroquel is slowly eliminated, and we see no change in her behavior, which is often the case. We still have to deal with the fact that some staff may feel that she still needs to be on, quote, something, but the patient is ultimately better off. The patient's memory is worsening, as we would expect, and she's becoming less active and aggressive, which tends to be the case as dementia moves into the more severe end stages. These are some principles that can be helpful when managing problem behaviors in dementia. One is that you must understand that these are common, and they often result in an ability to understand or communicate with the environment. There are no medications that are FDA approved for dementia-related behaviors, but they are often used off-label. Activity programs often yield the biggest benefit in treating problematic behaviors, and dementia-related behaviors and even psychosis may resolve as dementia progresses, and unlike psychiatric illness, rarely worsen from not using medication. Approaching assessment and treatment of behavior problems works best when done as a team, and bedside screening tests for dementia, such as the mini-cog, can be quick and useful. Thank you.